I would like to ask your opinion. So, who is convinced that DCB is an effective technology by raise of hands? Okay, so we are pretty much on the same room. Who is convinced that Paclitaxel DCB is probably the best technology, or at least the best proven technology for the time being? Who is convinced about the opposite, that sirolimus is the most convinced technology? There is some risks in using Paclitaxel. Okay, so I think the sponsor did a great job in inviting the right people at the Congress. Okay, let's look into the data. So the data is probably not the best quality data I have ever seen in the field of interventional cardiology, but we have some data, limited data, which in a way are leaving, I would say, the room over for different interpretation. I will divide the evidence into the 4 pillars: in-stent restenosis, de novo small vessel, de novo all comers unselected, and last but not least, bifurcation, which is basically what we have been discussing so far, because we do have some recent data out there. So in-stent restenosis is where all this started from. As you know, the DCB technology started by thinking that ISR would be the best possible indicated niche, and it's probably still true today despite the European guidelines. Here you see the type of study which to me is the most convincing ones. So DCB versus balloon. And here you see in 2 different settings, the same technology, Paclitaxel DCB, sequence please, that this technology is basically cutting late loss into 50% lower. Now, this is the type of study that FDA requires for every single device to be approved in the United States, and this is what the agent balloon, again another Paclitaxel eluting balloon, has put together, and thanks to which they are currently approved in the United States. This is the agent ISR, very large study, probably one of the few modern studies in the field of ISR. Why am I saying this? Because you have a lot of scoring balloon, see cutting balloon 24, scoring balloon 15, and perhaps more importantly, you have almost consistent intravascular imaging, which of course is a must. Yesterday, Dr. Elasi was showing his algorithm, and the first step was image the vessel before deciding what to do. I think this makes a huge amount of sense. And here, unfortunately, we have a bunch of studies with a lot of technology without IBUs, without OCT. It makes no sense. In this study was a lot of imaging, and you see that DCB here makes a huge difference in terms of TLR and target vessel myocardial infarction. So the MACE rate was in favor of DCB. What about DCB as an alternative to DS? Now things are getting more complicated, and the data are not so clear-cut in the way we should interpret them. First, if you take a Paclitaxel eluting stent, such as what they did in ISAR React, in ISAR Desire 3, you see that basically you have pretty much alike, similar results if you use DCB or DS in terms of late loss and as well as TLR. However, we know Paclitaxel eluting stents are not really the most performant stents. So if you redo the exercise based on limus eluting stents as an opportunity to treat this ISR, results are less clear. This is DMS ISR, which is very important. So these are in-stent restenosis after bare metal stent implantation, which most likely is no longer very interesting for us anymore. But here the message is that a DCB or a BMS or a DS in a BMS-related ISR is pretty much alike. Whereas if you redo the exercise in DS ISR, you have to pay a price in terms of late loss and in terms of TLR at 1 year. You see here, the result is almost twice as big if you use DCB as compared to DS. There are other studies showing mixed results. This is the PEPCAT China, telling us a different story. You can use DCB and DS and the result is similar. And we have the RESTORE study, again with the same technology, sequence please, basically telling us the information that a science stent would be better off than a DCB. So how can we make some reasonable interpretation out of all these apparently contrasting data? I think it's very important to understand what you end up with after your procedure. If you make a not wonderful result at the end of the procedure and you still have a reasonably low MLD, meaning you have not dilated the lesion enough, of course, DCB will not be a magic technology. will not get you to a situation that you were not after immediately your PCI. So cannot basically do the job instead of you, can maintain the job that you have reached, but cannot do the job instead of the operator. And that is probably the reason why some studies are okay-ish, like the China PEPCAT, where the MLD after the procedure was identical if you use a DCB or a stent, whereas in studies where the MLD was lower with DCB, of course, that result gets worse and worse over time. So this is the key message that I would like to bring in. And I guess with that information in our mind, we should interpret the evidence which led the guidelines to give a class 1A recommendation in Europe to use DES in patients with ISR. This is what our 2024 ESC CCS guidelines tell us. DES is recommended over DCB for treatment of in-stent DES restenosis. This is coming from this meta-analysis by Jacopo and colleagues, where you see that there is basically a significant interaction. DCB would be okay for treating an BMS-related ISR, but suboptimal compared to DES re-stenting if you have to treat a DES-related ISR. We need to interpret this data by knowing that in all these studies, imaging was not systematically performed, was very rarely done, and in fact the use of scoring balloon and aggressive lesion pre-dilatation before DCB was missing. So to be honest, my strategy has not changed. When I have a DES-related ISR, my first attempt is DCB. If the patient comes back with the NA gain in ISR, my second attempt is DCB. If the patient comes back with the third ISR, my third attempt is DCB. So that is what I do in my cathode. And again, this is mainly because I know that I need to come off with a good treatment during the procedure. This is a study that I think Dr. Elasi was showing us yesterday. This is ISA Desire 4, telling us the importance of doing not only an aggressive pre-dilatation, but even using scoring balloon. First, because they can get you to somewhat greater MLD at the time of the procedure, but also because that is a long-term investment. If you can dissect the lesion properly, you will have greater penetration of the drug associated with your DCB technology, and that will pay off in terms of lower late loss. So it's a bimodal treatment of action. First, you get immediately greater MLD. Secondly, you have greater penetration of the drug, and that is associated to a lower late loss. So what about the best technology, the best drug for treating ISR? Again, here the data are extremely limited. We don't have conclusive data, so basically you can remain on your opinion as you were before. We have overall 5 RCTs, 3 based on Limus, actually 3 sirolimus and 5 on biolimus comparing this drug with DCB, and the results are not entirely clear. First, we have some, I would say, for the time being, clear message that the same technology sequence based on sirolimus or paclitaxel elution is probably associated to very similar outcomes in terms of late loss. We have at least 2 studies telling us the same story, which are the 2 I showed you before. And then we have some apparently contrasting data for another Limus, which is biolimus A9. In this study, in the BioAscend, the outcome was identical, biolimus A9 versus sequent please. In this study was the opposite. Sequent please was better off than biolimus A9 elution, and apparently this might be related to the fact that biolimus A9 in this specific technology was perhaps not the best formulation ever. So the message here is that it's not only the drug which is eluted, but it's the technology through which the drug is eluted which makes a difference, which basically tells us a very important story. There is no class effect here, not even with respect to the agent which is eluted. Every single technology, even every single iteration of the same technology, would be associated to different outcomes. If you make a meta-analysis, you basically end up with non-conclusive data. If anything, I need to say, paclitaxel lutein balloon are coming off slightly better, because first, the evidence is more robust, for sure, and second, because in some comparative data, paclitaxel elution was better off than sirolimus solution. And I'm going to skip this one because basically the same story. Now, what do we know about the novo small vessel? Well, this is for sure, for the time being, the niche of DCB in de novo. This is an IPD meta-analysis of 3 RCTs, which I'm going to skip for the sake of time. I'm just going to show you the pooled analysis, Bello, Piccoletto, and Basket Small 2. Probably these are the most convincing data in the de novo setting, and basically here they tell us the story that the outcome is even better if you DCB instead of stent implantation, and this is a relatively long-term outcome. And what is very interesting is that the outcome seems to keep diverging over time. So perhaps bringing up the thinking that the benefit of this technology would not really be at 1 year. Perhaps at 1 year we are happy if we are non-inferior to DS, but very long-term follow-up could actually disclose something interesting. A very important study is Transform 1. That's a mechanistic investigation, but is again bringing us a very interesting observation. In this study, magic touch technology, so sirolimus solution versus sequent place paclitaxel elution, did not meet non-inferiority. Magic touch here was proved to be inferior to paclitaxel elution, and this is actually apparently mainly related to the fact that the more you dissect, if you use a paclitaxel DCB technology, the more you will get payoff at the end of your follow-up, and apparently here is the opposite. So if you have a very large volume, dissection volumes in this study, the sirolimus solution was not helping, actually was doing the opposite, which is very interesting. Is it the drug? Is it the technology? I think this is something we still need to understand, but this dichotomy of behavior is very interesting. Dr. Elasi yesterday was showing another Japanese paper telling us the more you dissect, the more your DCB is effective, and this is most likely true with paclitaxel. We do not know yet if that is the same for sirolimus, or at least whether this is magic touch specific or not. This is something that we will probably learn very soon, because at TCT will be a very big sirolimus-based de novo study to be presented. What about all comers, which is basically what we have done here with the Luca? We have been treating a very large LAD with the DCB only. Now, we have, again, no conclusive data. This is a relatively large study, interesting study. 170 patients randomized after successful pre-dilatation to DCB, paclitaxel-based DCB, versus standard ES, and this study told us the outcome is the same in terms of TLR and in terms of DCB. But this is a much bigger study, performed more recently. The cage-free study, unfortunately, performed with the paclitaxel technology, which is not available in Europe. So we do not know whether this is the best one. But in this study, basically, there was some price to pay in terms of TLR if you stick to DCB, and the price really came from relatively big vessel. So if we would apply this evidence to the patient we have just treated, we would anticipate that the likelihood that this patient would come back with an instant restenosis and the need for TLR would be slightly bigger if we had implanted a stent all the way. Then you have a lot of studies which I totally dislike that are trying to use DCB for shortening the APT duration. It's a no sense, because I think the APT is patient specific, not technology specific. But this was the rationale for the debut study, where basically they say, since I need to stick clinically to 1 month DPT duration only, I have 2 options. Either I implant a BMS or I use a DCB. So which technology is the best one? And this study basically told us that DCB is much better than bare metal stent after 1 month DPT. But this is basically not really valid evidence, because now we know that 1 month DPT is absolutely an option after many contemporary DES. I'm gonna skip this one, but this is another study showing that even in the large de novo setting, sirolimus elution is probably similar to paclitaxel elution, and this is the mechanistic study which is actually now leading to a large RCT where these 2 drugs are being compared. Last topic is bifurcation. We don't have conclusive evidence, but we have some recent evidence, again coming from China, that would entirely support the treatment strategy that Luca was planning to begin with. He said, I'm going to stent LAD and I'm going to use a DCB to treat the side branch. That was the plan. at the beginning of the procedure. And actually this approach is entirely supported by these data, where they did the same. They did main stent branching, provisional stenting, and then they randomized patient after successful stent implantation to standard balloon dilatation, kissing balloon and POT versus DCB, kissing balloon and POT. And this study is showing that by using DCB in treating the side branch is actually associated to a lower risk of MACE, lower risk of MI, and lower risk of target vessel myocardial infarction. I have to say I don't fully understand these results because much of the difference comes from a peri-procedure effect. Then we have also some late effect in the middle, but I don't understand how using a DCB acutely may be associated to lower risk of MI and lower risk of target vessel revascularization than a standard balloon. That I do not understand. The authors, if you take the time to read the paper, do not have the explanation either. They Google it in the discussion. I probably would think that we need to reproduce the data based on other studies, and I'm going to skip this one for the sake of time. I would say that for in-stent restenosis, DCB PCI is conclusively better than POBA. Despite this, that's what FDA keeps demanding. So you will probably see in the future a lot of DCB versus POBA comparisons in the ISR space, whereas the outcome with respect to DS, it's less clear. Of course, that gives a lot of room for interpretation of the data. I still use DCB as my first, second, and third strategy, and perhaps we want to discuss that. For small vessel DCB, it's a very reasonable and evidence-approved option. For large vessel, we are still in the gray zone. That is something that we need to understand. And for bifurcation, I think that it is very promising, but we probably need to have more data and bigger data to rely on. Thank you very much for your attention.